The knowledge base of what we do in medicine needs to have advanced to the point where you understand what a cell secretes, how cells communicate, and what growth factors are, and what an exosome is, and the different types of things. The medical industry as a whole, and in particular, I think Big Pharma, realized very early on that cell therapy was the way the human body works, and they had to get ahead of the narrative before the science of using your cells to help you heal got kind of out of control. Hey everyone, welcome back to the Zero Downside Podcast. I'm Dr. Wade McKenna, and as always, we are sponsored by moabtexas.com. I want to thank you for tuning in. We're going to have, I hope, a clinical therapeutic, tie it all together kind of view on the GLP-1s, because technically they're not the GLP-1s. They're GLP-1 and a GIP, and now with Retatrutide, they added glucagon. So you have a glucagon-like peptide 1, which is GLP-1. You have a gastric inhibitory polypeptide, which is the GIP side. That's the difference between Tirzepatide and Semaglutide. Tirzepatide is a GLP-1 and a GIP. And now on the market, you have Retatrutide, and not on the market yet. I think that Lilly has not released Retatrutide as a drug yet. I think it's 2026, 28 maybe. I don't think that the company that owns the rights to Retatrutide is really in a big hurry to compete with themselves when they already own the biggest drug in that market. And that may be part of what's going on from a regulatory standpoint, just a theory. But with that, we don't write for a lot of Semaglutide at our clinic. I think that the side effect profile is, the GLP-1s kind of got a bad rap even with Semaglutide, or Ozempic is the drug name for that. But I think that with Semaglutide, there's a lot more nausea and a lot more failure of care, meaning that even people that could tolerate it hit a little bit of a wall later on in the therapeutic use of it and kind of stop losing weight. And there's a little bit of bounce back when they stop. But from our perspective in the clinic, we just saw too much gastric intolerance and side effects, nausea, to be able to use a lot of it. With the peptide access that we have, I think that Semaglutide just kind of fell out of favor with us. Even though it's a little bit less expensive, the side effect profile is just really not been worth it. I think in our clinic, 20 to 30% fall out on the Semaglutide side, and this is a few years ago, within the first 2 to 3 months, because it just causes too many side effects. They couldn't tolerate the constipation or the chronic nausea, just feeling terrible for the first few days after they took it. With Tirzepatide, we really haven't seen that, certainly not to that degree. I think that most people on the GLP-1 with the GIP, which is Tirzepatide, have seen a significant better tolerance from a gastrointestinal perspective, feeling better, not having the fatigue and muscle loss associated with Semaglutide. I think that Semaglutide, it's really difficult to preserve muscle on the GLP-1s. I do think that Tirzepatide represented a significant advance in the preservation of your muscle mass. I think that the addition of glucagon in Retatrutide, which we don't formulate Retatrutide, we formulate triple G, which is how the lab has designated a GLP-1, a GIP, and a glucagon component. And I think that the therapeutic uses of Retatrutide from a clinical perspective are way more all-encompassing than just weight loss. There's going to be, and is, but you can't, it's not readily available, a significant amount of data out there on restoration away from fatty liver disease and early liver failure. The data points to the fact that there's going to be some significant enhancements possible to what is most GLP-1 therapies that are out there, especially the mass marketed versions, where it's really, people focus on cost, but not focusing on the right aspect of cost. It's about how much of something are you getting, not how many units is the shot, but how many milligrams is the shot. What's the effective dosing schedule, and what's the rapidity with which you can advance your own dosing schedule away from side effects, but up to therapeutic efficacy. And I think that's where physician management with easy access to, you're not just using some pen where the dosing can't be regulated or changed easily. It is predetermined by how many pens at that dose are you buying, instead of here's a bottle of peptide and here's the strength at which it is mixed. And if you take this many units in the syringe, it's this many milligrams. And if you take this many units in a syringe, it's that many milligrams. The biggest question and misunderstanding we get is people trying to, they've made it almost impossible to kind of compare apples to apples, because they're saying, well, it's $300 a month. Well, for what? Like, what's your dose? Are you on the smallest ineffective dose of Semaglutide? Are you on a 2 milligram dose of Tirzepatide when the therapeutic efficacy was best at 15 milligrams a week, not at 2 milligrams a week? We'll have patients come in and say, well, I tried Tirzepatide and it didn't work for me. Or I was on Mounjaro and my doctor, my insurance would approve it, and they got me up to 2.5 milligrams a week, or they got me up to 5 milligrams a week, and I just didn't see a difference. Well, you weren't even close to the therapeutic indications for Mounjaro when they stopped your Mounjaro therapy. So, and oh, by the way, those 4 pens that you get, which is what that patent is for, it's the same whether you're on a 2.5 milligram, a 5 milligram, a 7.5 milligram, a 10 milligram, a 12.5 milligram, a 15 milligram. They're not, most of Western pharmacy isn't even charging you for the dose of the peptide. They're charging you for a weekly subscription fee or a monthly charge. It should be based on, what are you paying for, what milligrams of a peptide are you injecting? Because the difference under a physician-guided program using a peptide therapy that is designed to help augment your health and overcome insulin resistance and get you healthier and out of that obesity loop of brokenness, the burning of fat molecule again instead of storing everything you eat. Actually, processed food has increased the glycemic index of almost everything. You can't eat a bite of food if you're broken metabolically without insulin being floating around in your system forever. And when that happens, you can't burn a calorie. Insulin, that's part of its job, is to prevent you from losing that calorie that you ate. It wants to store it. It's trying to save for a rainy day. We're trying to break that cycle to where you could actually burn fat again. That's incredibly difficult, but not if you're on the appropriate peptide therapy. So peptide therapy would be focused on fixing you metabolically, where you're not insulin resistant, to where you can burn fat again, and, oh, by the way, preserve muscle. The reason that there's so much muscle wasting with fat loss is because if there's insulin still in your bloodstream, you're going to hit muscle mass for your glycogen stores. So if you're trying to work out and you get that 20-minute fatigue, you'll burn what's in your gut first. Like if you have a high-protein diet, you'll hit that protein first. But after that, within about 20, 30 minutes, especially with some prolonged exercise program, you're going to start hitting your muscle mass for glycogen, and you're going to feel the fatigue and the soreness and the inflammatory load. And insulin's a very inflammatory molecule, by the way. And so if you're resistant and you're staying in this chronic meta-inflammatory state, that's where the obesity, which also is a meta-inflammatory state, it's just kind of a really hard path to dig yourself out of. Triple G, or what is out there on the outside of Tirzepatide peptides for muscle mass, is that it might actually make a huge difference in not only the preservation of muscle mass, but the building and development of muscle mass. Clinically, we see thousands of patients over the last, I've been in private practice. Next year will be the 30th year of private practice, which is really hard to say out loud. I didn't realize, I never really think I'm that old until I look in the mirror. And then I always wonder who the old gray hair guy is staring back at me. But the old gray hair guy looks a whole lot different now than he did 5 years ago. And my energy levels, my fatigue, my obesity, my muscle mass, mental clarity, performance, all are much better now than probably even a decade ago. And it wasn't because I've gotten younger, it's because I've gotten healthier. But it wasn't that I wasn't making healthy choices before. It's just that the scale was so tilted against you when you're in insulin resistance. Here's how, we always talk about how do you know when they're lying to you? Every patient that has a weight problem knows someone that eats way more than they do that stays thin. And you have had the personal experience of almost starving yourself and not losing weight because you start losing some muscle mass. So you may lose some weight, but you certainly didn't fit in your clothes better. With the addition of Retatrutide, or in our practice, Triple G, or G3, which is what I call it all the time, but everyone keeps reminding me that's not what's on the label. I think that the difference is the myopreservation and being able to build muscle. We have a deal structured with a device to help you measure body fat and muscle mass that we're going to be able to talk about very, very soon, that has been really instrumental in helping me guide people's peptide therapy. Just with me, the difference between 231 pounds and 210 pounds. I kind of hit a wall on Tirzepatide as a patient. Never really took max dose, certainly not consistently, but around 10 milligrams a week, or really going to a regime of every six days instead of a week, made a huge difference. And it got me out of the metabolic brokenness of insulin resistance. And I worked really hard to stay in ketosis. We don't eat a lot of sweets at my house outside of my 12-year-old daughter, who, thinks that candy is its own food group. And she's doing way better because now she's an athlete. She's our family's little volleyball star. But still, in my age group, you can't eat like that and feel good. You're metabolically broken. Your insulin levels stay up. It's a very glycemic index type of something to put in your mouth. The goal is I could stay in ketosis as long as I kept my fats up. That was the hardest part, was getting enough fat. But I still kind of hit a wall around 230, and I did lose a significant amount of muscle mass. With the addition of Triple G, I went from 231 to 210 and actually added 5 pounds of lean muscle mass. And we know that because using the device that we talk about, we were able to directly measure that. And it's incredibly efficient, inexpensive way to guide your body composition battle, and which is really what it is for most people. The battle of the narrative, they won already, because they've convinced everyone that it's about calories in, calories out, and it's what you eat. But those are the same people telling you that vitamins aren't important because it just gives you expensive urine. So they're kind of talking out of both sides of their mouth about it's not really, you're responsible for the fact that you're fat. No, if you're metabolically broken, again, just think. Do you know people that in your same age group that are way less active than you, don't have as much body strength as you, eat terrible, eat twice as much at a meal, and stay thin? And you're struggling, worrying about every bite you put in your mouth, and gain weight over a weekend when you just took your eye off the ball for 1 minute. Yes, that means that there's something else. Maybe being metabolically broken is more of a part of being inflamed and being obese and fatigue and not having the energy levels and mental clarity. Maybe it's way more about insulin resistance and your metabolic resistance and what we've done to this over the years that have destroyed it generationally, not just individually, that there's ways to overcome, and peptide therapies may be the way to do that. So just in my own battle. So that was just to tie up the loose end of how they won the narrative on weight loss, because it's billions of dollars in industry in the US. And honestly, it's more about getting you fixed and not being obese, not just taking off weight. It's about how do we get you healthy? Because if you're healthier and you're not inflamed, you're not fat. You can navigate the stream. Now, it may not be an overnight solution, but it is a solution, and it does work. I think that there's so many things out there that could help people in their weight loss journey and your overall battle to health, like certain workout programs. I think they're incredibly effective. Do I think that there's any of those programs that aren't augmented by the use of certain peptides for patient? No, we can always augment whatever you're doing to help you get a better result. If we dose you appropriately and we're nimble with our dosing and we're not so conservative that we're afraid that because you bought those 4 pens, that's going to be your dose for the next month. Once you're not having a side effect, and we can slowly step up your dose, because again, you're going to have a bottle, and it's just about how much you pull up of that bottle is what your dose is. We can safely and effectively help you navigate the stream to where we just want to keep you off the shore, right? All the trash washes up on shore. We want to just keep people in the deepest part of the river flowing forward to a better result. And it's going to be about, how are you processing the calories that you eat? How are you restoring and maintaining muscle mass? I will tell you from my own personal journey as now having lost 100 pounds, that it's incredibly difficult to be on a strength program, stay out of fatigue, not feel like you're depriving yourself, and actually feel satiated outside of peptide therapy. The biggest upside of peptide therapy is that feeling of satiety. I mean, even people that have gone through the gastric bypass route, the sleeve, the lap band, the significant surgeries, there's a pretty significant bounce back for a lot of patients. I think they can be incredibly effective and life-saving in some people for sure. But do I think that needs to be people's first line of defense? No. It needs to be the last act of a desperate person that has tried everything out there and didn't get a result. Peptide therapy should not be the last act of a desperate person seeking any kind of result. It needs to be part of the therapeutic regime to help you navigate the water a little bit, maintain muscle mass, stay out of insulin resistance, be able to actually feel good. So satiety, that sense of being satisfied, like you're not still hungry. What's the old saying about Chinese food, right? Like you eat Chinese food and an hour later you're hungry again. That's what being overweight can be like. It feels like you never were satisfied, so you're depriving yourself. That's incredibly difficult to stay on a routine where it feels like you're depriving yourself, and so much of our happiness and social activities are surrounded around food, just environmentally. Like, that's why it's called a comfort food, right? It wouldn't be called a comfort food if it didn't make you comfortable, if it wasn't part of our innate sense of happiness, is being able to eat things that make you happy. And some of those things may not necessarily be the thing that helps you stay lean. But being satisfied and feeling good, that sense of well-being, are all effects that we can help drive with appropriate peptide therapy. So that being said, this is going to be a compare and contrast. Do I let Semaglutide versus Tirzepatide? We don't use a lot of Semaglutide anymore. If someone's on Semaglutide, they've had good results, they don't have a lot of side effects, can we move them on to a Semaglutide that would be way easier to dose, way more formulaic as far as stepping up your dose towards effectiveness and down your dose from side effects? Yes. Is that ever my first line when I have a patient that's metabolically broken in our clinic? No. Is the first line of defense still usually Tirzepatide, just from a cost perspective? Yes, because the other alternative that is going to be known as Retatrutide in our clinic is triple G. Do I think that it might be a little bit more expensive-ish, depending on dosing? Yes. But at max dose, Tirzepatide at 15 milligrams a week, because you can formulate a bigger bottle in the lab, and now in that bigger dosing, you can actually add an amplifying peptide called RA that makes the GLP-1 and the GIP work synergistically together even better to overall augment the metabolic repair that goes into weight loss. You see how careful I have to be on how I say some of this? Like, it's kind of ridiculous, right? But I want this episode to be able to stay up. And so that's the reason for the kind of word salad that can come out sometimes when you're trying to stay within wording that keeps the episode up and accessible. Is we have to be really careful on the way that regulatory-wise things are described. If you're a patient, we don't do this. If you're a patient, I can have a frank discussion with you because we're covered by doctor-patient privilege. If I'm talking to another physician, I'm covered by peer privilege. What I'm not covered by peer privilege or doctor-patient privilege on is a direct discussion on the internet. But we can discuss in general the science behind what's published on all these peptides, and that isn't medical misinformation. It's just science of the way peptide therapy works. Bigger doses work better for most people. Getting to the dose that's effective for you should be less than a 6-month protocol to get you to the appropriate dose, and it shouldn't cost the same at smaller doses as it does at a bigger dose. That's like charging the same for a 6-ounce patty as you do a 12-ounce patty. It doesn't make any sense. Like, everything is priced when you go to the market by the ounce or by the half. Like, when you're buying beef, that's the way we should look at your peptide therapy, is what is your milligram dose and what is the most effective dose for you. I think that that's the difference at our clinic, is we work really hard on helping tailor your protocol towards effectiveness and away from a side effect. And, oh, by the way, if you are losing some muscle mass, or you do have some problems feeling alert first thing in the morning as you've lost 50 pounds, are there some other peptides that you can add to that makes a dramatic difference in the overall way you feel? Yes. Some of the side effects of some of the peptides that we'll use to help you navigate the storm, one of the side effects is sense of well-being. That sounds like an okay side effect for me. A little bit of a tan. Wow, I'm okay with healthier skin color and your absorption of light and frequency being better. That sounds like a good thing. What about healthier hair and skin and collagen? Wow, that sounds like a great side effect. all that's possible in peptide therapy, especially as you lose weight. It becomes more and more important because you don't want to lose weight to look older. No one wants to lose weight. For me, the weight loss journey was just about, I need to get down to a point where my knees didn't hurt all the time. For me, that was around 280. Like if I'm under 280, my knees don't hurt. If I was over 280, my knees hurt all the time. 3 years ago, I was 310. I could, and really 10 years ago, I was 310, but I could strap it up a little bit, go on peptide therapy, deprive myself, go on a protein diet, deprive myself of a lot of stuff, and I could get down and I could lose 20 or 30 pounds within a month to 2 months just by really working out and being kind of focused and going to a bunch of protein drinks and having creatine in the morning. Like I could do it. I don't have to do that anymore because I'm metabolically fixed. And that was based on peptide therapies that helps me maintain some muscle mass and not be insulin resistant and actually being able to burn fat again. Your body doesn't want to burn fat. It's trying to store everything you eat because it still thinks it's trying. God did a really good job of designing this where it doesn't starve very easy. That's a great thing, unless it's 2025 and you have readily available access to every drive-through on your way home from work. That's the other thing, honestly, if you talk about cost of peptide therapy, and this is like just one of the things that comes up all the time is I don't have any fast food wrappers in my car anymore, right? Because I'm not stopping by a drive-through on the way home and not even counting it as a meal. I do take in a lot less food, but I don't feel like I'm depriving myself of anything. And it's a lot. All I want to do, and all peptide therapy is designed to do, is help make healthy choices easier. Everyone wants to make a healthy choice. It's just not easy. Peptide therapy, not being metabolically broken, can make it easier. So that's the biggest difference between mass-produced, mass-marketed versions that you're going to see on TV with some movie star injecting themselves with a shot and a custom designed protocol where you're pulling up your dose and being nimble with your dosing. That would be the difference in being at our clinic. So it's about the difference with Tirzepatide, Retatrutide, your metabolic issues, and us just keeping you as healthy as we can. Thank you again for your attention. I know this was kind of a cursory surface view of this topic, but we obviously feel passionate about how we manage patient care. I genuinely want to thank you for tuning in. Please like, subscribe, hit the notification bell. But again, thank you so much. Check out the website, moabtexas.com, and let us get you started on your own health journey. Thank you so much.